Thank you and good morning. I trust everybody can hear me okay. And I am delighted to be here today to talk about a program that's near and dear to my heart, and I know Alexis's heart, and many of the other people who live in New Jersey who have been positively affected by advanced pain management without heavy reliance on opioids. My task this morning is to take you through a little bit of a history of how we got here when it comes to the use of opioids and advanced pain management without using opioids. So I am, as Dr. Adenero said, I don't need to introduce myself. I have no financial conflicts. And I'd like to just bring up this slide, which I frequently do. Life is about choices. This is important because, and here's what you see. Your child's being eaten by a camel. Do you save your child or do you take a photo? Well, this is a little tongue in cheek because when it comes to opioids, we all have to make a decision. Do we want to prevent people from getting addicted and dependent on opioids, or do we want to not be part of the solution? So today, Alexis and I are going to present part of the solution, or what we believe is the right approach to managing patients who come in with acute pain. If we get a timeline of how we got into this position, there's several areas that we need to look at. In 1986, Doctors Foley and Portnoy published a paper in the Journal of Pain that opioids were safe to use for acute pain. And not only that, recommended that we never withhold them from patients. A couple of years later, the black tar heroin expanded past San Francisco in a distribution system that, honestly, not trying to be funny, was very similar to Amazon. Same day delivery, good quality goods, and easily accessible even to your home. Purdue in 1996 released a new non-addictive pain medication, OxyContin. And in 1998, the VA and the Joint Commission came out with their fifth vital sign, saying that all patients required pain assessment so that we can treat them aggressively for pain management. What happened then, and this graph has been out for a while, but it's important here because that was 1998, and that's just a year later, we started seeing the rise of prescription opioid deaths right after OxyContin came out and was said not to be addicting. And as we tried to control that, more and more people went into heroin. And we see that in wave 2, which started in 2010. And as we tried to really stop the cartel from bringing in heroin, which we were never successful on, we started getting more and more synthetic drugs, particularly like from countries like China and otherwise. This synthetic drugs tend to be so concentrated that they can easily be sent even through the US mail. So, and if we compare this to our timeline that we just saw, what we realize is the fact that maybe a lot of the things that we just talked about really contributed to some of the results that we're seeing in our community with the rise of opioids, addiction, dependency, and overdose and death. If we look at some of the numbers, emergency departments across the country see approximately 151 million patients a year. And interestingly, 42% of those patients come to the emergency department for the main reason of having pain. And 17% of those nationwide receive an opioid. And we also know that opioids usage has dropped in the emergency department, but nonetheless, 2 million people are really guessed to have opioid dependency and addiction, and 500,000 heroin. These numbers are very difficult to determine. But what's an acceptable death rate? You know, right now we're tracking over 230 patients a day. What is a good way of bringing that down? What's a good number? But if we look at all this and we compare this to the death rate from all the wars and everything that's going on, we have more people dying from opioids than we did from all the wars. But let's take away all these numbers and just focus on one. 17% of ED visits receive an opioid. So it seems like that's a good focus. If we can bring down 17% to 10%, a 7% reduction, actually it's more than that, but a significant reduction in opioid being prescribed, but still manage pain aggressively. How about if we were able to bring it down to 5% across those 151 million emergency department visits that were coming in to the nation's emergency departments? And if we look at what happened with the pandemic, during October 2019 to 2020, we had 250 people a day would die. This is the highest number of death rates in the 12-month period since the CDC started tracking opioid overdose deaths in 1999. The problem continues to even get worse when we look at health disparities in different populations. Here's an article from May 12, 2021, and this was talking about the coronavirus, and the headline is obvious. Opioid overdose deaths among Black men in Massachusetts spiked 69%. Other statements and comments that were out there is, this is another date timeline, but I think what's interesting is the last comment that was in this article. The medical evidence is clear that medical assisted treatment saves lives. And in the study in France, 80% decrease in overdose deaths from using MAT and making it readily available. And I'll get into why that's important in a moment. And here it is. We have a three-part solution that is called ALTO, and there's three parts of it. And it really deals with prevention. We'll talk about that, treatment, and harm reduction. So the prevention part was the original ALTO program. And what this was is a very simple philosophy. Somebody comes in with acute pain. We want them to feel better. We know that we can give them opioids, but we have a problem with addiction. So instead, we want to give alternatives and avoid using opioids and hence avoiding addiction. We know one thing that's absolute science and absolute true. If somebody doesn't take opioids, they're not going to get addicted to opioids. Part of this is looking at pain receptor management. I don't want to go into the specifics, but we also have pain receptor medications that can block some of those receptors. And hence, Alexis and I put together a pain fellowship program that looked at advanced multimodal pain management in the emergency department. And we looked at the 5 key diagnoses that were the #1 diagnoses that presented to the emergency department with pain. And we searched the world literature and came up with non-opioid treatment for these. I don't want you to memorize this. Alexis is going to go over it in tremendous detail. But these were evidence-based protocols to manage pain. And we have all the evidence listed. Again, not worth going through this, but it's available to anybody who's on the call. What we found over our study period is that prior to using ALTO, we at St. Joseph's University Medical Center were prescribing over 4,000 prescriptions in a 6-month period for opioids. When we finished tracking this, and we had an 82% reduction on opioid prescriptions. And when we looked at that magic number of 17% as the national average, when we looked at what St. Joe's was doing, we were down to a 2% number of opioid prescriptions. We were not opioid free like many people suggested we were. We were really there taking care of acute pain, taking care of patients, improving patient satisfaction, and avoiding the risk. Part 2 of the stool is MAT, giving medical assisted treatment and an opioid overdose recovery program. The main drug that we use for that in the emergency department, there's several we can use, but it's buprenorphine, and Alexis will talk more about that as we move forward. But I wanted to show this graph, and this is really looking at using methadone for a heroin user, but let me track what happens to the user. This is somebody who's addicted to or dependent on heroin, and they wake up in the morning and they feel sick. So this is the sick side of the graph. And this is a timeline. And they seek their heroin dose, and then eventually they feel high, and they continue to shoot up during the day, but all day they're stopping themselves from getting sick. And then eventually they cycle again with the same situation every day. And if they can't get their heroin, they stay sick all day. This is the same graph, same person who's taken buprenorphine. And instead of seeing the peaks and valleys, in this case, they're taking methadone, same graph for buprenorphine, what we see is this tremendous leveling off, and the patient is able to stay straight in their mind and function relatively normally. So that's another goal that we have. We add that to an opioid reduction program where we have opioid counselors to do that. We started this in 2016. And I'm going through these quickly just so we can really get to Alexis's part. But because of this, we saw a continued reduction in long-term overdoses and addiction, and many patients who stayed in long-term treatment, 35% stayed in long-term recovery. And our spokesperson for the program was Josh. He was a recovery coach. He was a patient of ours in Paterson, New Jersey, who lived on the street under the bridge in Paterson. He eventually got into recovery. He got his MBA. He now works for the facility where he received his treatment. He now has an apartment over the bridge that he lived in when he was on the street. So a success story. Many don't have success stories, but nonetheless, we try every chance we can. Another thing that we can talk about, and we won't spend a lot of time here, is harm reduction. But the biggest part of harm reduction is something new in the prescriptions of the opioids. And that is the second bullet here, is to prescribe naloxone or Narcan to those patients who are at risk for an overdose, who are on chronic opioids for a medical problem. Part of their prescription should include naloxone to help decrease the amount of overdose, even unintentional, that may happen. There are several other things here that are listed, which I will really not go into at this point in time, but happy to answer Q&A later. We worked on getting federal initiative here, and we were able to go from a meeting with Senator Booker in May of 2017 and eventually got Congressman Pascrell to get on board. And we had 2 bills that went to Congress. And eventually, with the help of the Energy and Commerce Committee and Dr. Burgess, who is out of Texas, we were able to get President Trump to sign into law the ALTO Act and the POWER Act, which focused on using ALTO principles to manage acute pain and giving buprenorphine when needed for those people who were addicted or dependent and needed to get off opioids. The timeline for this journey was in 2014. Alexis and I started the Acute Pain Fellowship, and she was our first fellow in that program. And this ends up really with our biggest success in December of 2019, when not only was the ALTO Act signed into law, but we also got funding to help support hospitals to develop ALTO programs and help manage their patients aggressively without the use of opioids. So to end my portion here, I just want to say that if it's not us, if it's not all of us who are on the conference call today, if it's not everybody, then who's going to do this? Who's going to protect our public? Who's going to protect our patients? Who's going to protect our family? And who's going to protect our neighbors? We have to be part of this solution. So thank you very much. I want to turn this over to my colleague, Dr. Alexis LaPietra. Let me get out of my signing. Well, she took care of that. Thank you so much.
Thanks, Mark. Appreciate it. So I'm Alexis LaPietra. I work with Mark at St. Joe's, and I really appreciate you guys hosting us here today. We are going to continue with this conversation about alternatives and opioids. We're all very aware that we're facing a pain management dilemma. And as clinicians, this is really paramount in our practice to understand We must address pain, both acute and chronic, but we must respect the harm that is associated with opioids. However, we have to remember that opioids are very important. We do not want to be living in society where opioids are used for everything. That would cause significant devastation. It already has. But we do not want to live in a society where opioids are used for nothing. Opioids are an important part of pain management. Opioids are very necessary for the management of chronic pain, for end-of-life pain, and for significant catastrophic injuries we see in the hospital. So we really do have to find a solution and a middle ground where we can appreciate when opioids are appropriate, and we can empower ourselves as clinicians and the community to better understand the impact opioids can have. So this is just a cute slide that reminds us that we have to keep calm and respect opioids. I liked in the beginning how we talked about if we just had a little more education. And unfortunately, that lack of education did lead to a lot of devastation. So in 2021, it is no secret that opioids must be respected, and opioids do have significant harm. Now, lots of the medications we use for healthcare have significant harm. We talk about the harm associated with it, and unfortunately, we've learned our lessons. One really good example is insulin. Insulin is extremely, extremely dangerous. And when insulin was first introduced, there were deaths. We did not respect or maybe fully understand how significant the medication was and the effects it had on the body. So this analogy is very applicable to opioids. They are important. Insulin is important, but opioids are dangerous. Insulin is dangerous. So it does not mean we demonize opioids. It does not mean we pull them off the shelves. It means that we empower the entire community of medicine and the entire community of the United States and worldwide to have the conversation and to talk about when we use opioids, what the risks are, and more so to talk about what we can use instead of opioids, because we are very lucky in 2021 that we have so many options that will provide relief without reliance on opioids. And I want to talk about why opioids are dangerous. They are dangerous because they work really, really well for pain. There is a large dopamine spike in the brain when you take opioids. This dopamine spike occurs naturally in our day-to-day life and is associated with encouraging pleasurable activities. So as human beings, if something is nice and we're enjoying this activity, the dopamine in our brain is what imprints on us, you should probably do that again. So when we have intimate relationships, when we eat a delicious meal, that imprint of dopamine allows us to say, you know what, next Friday night, we're going to go out to dinner again. This place is really good. When we take an opioid, that dopamine spike is massive, and it goes above any dopamine that gets released with day-to-day activities. So this is great because if you're having horrible pain, we want that pain to be masked by that large dopamine spike. But unfortunately, that dopamine spike can be so euphoric and can be so pleasurable that it starts a cycle where we're seeking out that pleasure, we're seeking out that dopamine to cover up more than just pain. With the ALTO program, our goal is to come up with a multimodal response to pain. What are the different agents we can use and we can stack together in order to chip away at the pain, so we are not totally reliant on just masking the pain? Can we actually treat the pain? What kind of pain is a patient having? And is there a targeted treatment for that pain? And if there's not, and the pain is very significant, then we understand we need that dopamine spike. We need that masking of opioids, but we should not just go right there because we know the harm associated with that. when we look at all of the targeted treatments we have for actually addressing pain, the base, the foundation of pain should be addressed with anti-inflammatories and acetaminophen. This is coming out of a decade of data when we look at all kinds of very painful scenarios and we give patients opioids and we give them alternatives. And you know what works better? What we have found are that a combination of anti-inflammatories and acetaminophen dosed 3 times per day, that's the TID, is very, very helpful in taking the edge off of severe pain. And in most instances, allows the patient to avoid opioids. This is mostly for acute pain. We also are gaining a lot of evidence about the use of topical medications. These are medications that you apply directly to the area of pain, whether it's a cream or a patch, and it allows that medication to actually get targeted to the area of pain, and it bypasses the need to take medications by mouth, because there are certainly patients who cannot take ibuprofen or Aleve due to medical issues, or acetaminophen, Tylenol, due to medical issues. So let's just think about what's in our toolbox and let's layer these on. And this goes, I could speak an hour about all of these medications here. This is to highlight that there is robust data in medicine to say trigger point injections, soft tissue injections, nerve blocks or ultrasound guided regional anesthesia, non-pharmacological interventions, nitrous oxide, ketamine, gabapentin, dexmedetomidine, and there are many, many more. All have data to say these are opioid sparing. We should be educated on how to utilize these medications. And if you have a population that is experiencing pain and you feel you only have 1 or 2 options before you move to an opioid, that should just say to you as a clinician, I need to do a little bit more homework and I need to build my armamentarium. Because in 2021, there's a lot going on under this pyramid before we get to opioids. So again, we need to exhaust the resources we have. We need to capitalize on targeted interventions for the treatment of pain. But if we are not successful, we always have the opioid. The opioid should rarely, in the outpatient setting, be a first line intervention. We must give our patient population a chance to reveal to us that opioids are necessary, because a large percentage of patients will not need them. But again, if they do, we always have them. And I have here in parentheses MSIR, that is morphine sulfate immediate release. And we're going to talk about that in just a second. And then of course, IV opioids are really at the top. They're the apex of pain management. They will absolutely address all of the pain needs someone has, because they just grossly mask the pain and they allow that pain to be washed away. But again, I want to remind you, this is a masking mechanism. This is not a treatment mechanism. And if we can treat, we should always treat. So when we think about something like back pain, which is very frequently managed in the outpatient and the inpatient setting, we were rather reliant as a country on opioids as a first line. So all the way back in 2015 and 2016, researchers were saying, this medication is rather potent. We see a lot of people with back pain. If everybody with back pain is getting an opioid, we are going to have a lot of opioid use. And there unfortunately comes dependence with that liberal opioid prescribing. So research revealed when you prescribe opioids as a first line versus alternatives as a first line, the opioid group doesn't do as well. The opioids do mask the pain. They also lead to sedation, nausea, constipation. But when we lead off with alternatives that actually treat the inflammatory pain most commonly causing the back pain, we see relief. We see patients up and moving around. We see less surgery. We see fewer days missed from work. So again, if we can treat that source of inflammatory pain as opposed to simply masking it, we reduce some of the side effects and we reduce some of the harm. That is not to say that the anti-inflammatories and acetaminophen do not have harms. Every medication we give has side effects, every single medication. So there are folks that will not be able to tolerate opioids, and we accept that. We may have to use opioids. But if patients can tolerate the alternative pathway, it must be the pathway we choose first, because as Mark said, there is very little risk to no risk of developing opioid misuse, abuse, or opioid use disorder if you never take an opioid. Additionally, just this year, kind of verifying all of the research that we had from 15, 16, 17, 18, 19, we had another very large study that said, what do we do with patients who have musculoskeletal pain? One of the most common reasons we see folks inpatient and outpatient. The researchers gave each group of patients a certain medication combination. These are the most common medications we give nationally. So it's ibuprofen and acetaminophen at a 400 or 800 dose. It's Tylenol with codeine. It's Vicodin. It's Percocet. This is what we use. These are the tools in our toolbox. So let's give this to all comers with musculoskeletal pain. And gosh, does one work better? Can we say, we really should be using opioids? That group did great. Or can we say, I think that ibuprofen group did well. What we came up with is everybody did the same. If you got Percocet versus ibuprofen with acetaminophen, there was no difference in the pain reduction. If there's no difference in the pain reduction, but we have a significant issue with opioid abuse, misuse, and death, in patients who can tolerate the anti-inflammatory combination, that is what we must choose. If that patient population does not do well and they need to escalate, that's fine. We know we always have the second step, which is the opioids. But if all else is the same, let's go for the combination that has the least overdose death associated with it. So to start off with, when we think about sprains and strains and headache and back pain and elbow pain and knee pain, all of this inflammatory pain that we manage every day, let's follow the research. Let's look at the vetted algorithm for what actually works, and let's do that first. And again, that's Tylenol 1,000 milligrams, ibuprofen 400 milligrams given 3 times a day. Folks can take it with breakfast, with lunch, and with dinner. It's easy to remember. They take it after meals. They do this for 5, 6, or 7 days, and most inflammatory pain is dealt with without introducing any opioids. Additionally, if patients cannot take the by-mouth anti-inflammatories because they have heart disease, hypertension, trouble with their stomach, trouble with their kidneys, we do have now over-the-counter anti-inflammatory creams that work really well. The evidence is wildly supportive of topicals for inflammatory pain. They can combine that 3 times a day with the Tylenol. And then, of course, remembering non-pharmacological interventions like physical therapy play a very big role and getting folks back to their functional baseline and back to work. I do want to switch gears and talk a little bit about some of the most common opioids that we use and some of this emerging data about what opioids should we be reaching for. Are some better than others when we think about misuse potential? And can we empower ourselves as clinicians and empower our patients to better understand that we do have a choice when picking an opioid, and some might be better than others. Oxycodone is the most commonly prescribed opioid in the country. It's also the most commonly abused. Now there's a couple reasons for that. It's all over the community. You can pretty much find it everywhere just because that's what everybody's prescribing. But additionally, it has a significant dopamine spike when compared to other opioids. It is the most desirable when you talk to the opioid community, the folks who are looking to abuse or misuse opioids for euphoria. Oxycodone is the most desirable. And when we give oxycodone to patients in pain, and we give other opioids to patients in pain, and we say, did it take away your pain? The answer is yes, all the opioids do. Well, did you like the oxycodone? Would you like to take the oxycodone again? Would you ask for another prescription because it was likable? The answer is yes. Oxycodone is likable. The dopamine spike is more. If opioids all help reduce pain, but some cause a lot more euphoria and are linked to continued use, that's a problem. Additionally, hydromorphone, very potent opioid. It's called Dilaudid. We give it in a by-mouth formulation and we give it in an intravenous formulation. And there are studies out of Canada that have taken folks who do use intravenous opioids daily, and we give them heroin and we give them Dilaudid. We ask them over a period of time, when we give them each formulation, they don't know what they're getting. We say, tell us when you got the heroin. These are folks who use heroin every day. Tell us when you got heroin, tell us when you got Dilaudid. And the answer is they can't. They cannot tell the difference between that IV push of Dilaudid versus the IV push of heroin. So we don't want to pull the Dilaudid again. We're not trying to demonize the Dilaudid. We're trying to figure out how to do this better as doctors and clinicians. How can we administer these potent medications that are important in medicine, but how can we be more judicious? So one option is, instead of pushing that medication into the IV rapidly, we may be doing a better service to patients if we allow a slow infusion of that medication. The dopamine spike is less, but the pain relief is the same. And morphine sulfate immediate release has been around for a very, very long time. It was the medication opioid of choice for pain relief prior to oxycodone. Now, morphine sulfate immediate release is not very euphoric, but it's very, very effective. So in 2021, when we're having issues with opioids, let's look at what we have available with our opioids and pick one that might be better. So if morphine sulfate immediate release is less euphoric, but just as effective, if morphine sulfate immediate release is less desirable, but just as effective, let's think about starting to reach for that again, like we were doing 30 years ago, and reserve that oxycodone for patient populations that morphine sulfate immediate release is contraindicated in. And tramadol, I could talk about tramadol for an hour. I'm not going to do that, but I do want to just say the words on the screen here. Do not use it. Tramadol was what we were hoping to be a bridge between alternatives and oxycodone. It is not a bridge. It is an opioid. So if you're giving tramadol and you feel better about giving tramadol because you're not giving oxycodone, unfortunately, that good feeling is not justified. It's just as problematic as the opioids you are trying to avoid. This is a very busy slide, but I want you to see the harms. So all the harms you associate with opioids must be applied when you think of tramadol. There's significant harm associated with it. There is a majority of the population that doesn't actually metabolize tramadol into its active metabolite of morphine. It won't even work for that population. There's a percentage of the population that rapidly metabolize tramadol, and they actually can have significant sedation and significant respiratory depression. It's just not a great medicine. If you have patients in your practice that are on tramadol and they're stable, that's great. But if you have patients that are naive to an opioid and you're just trying to figure out what the next step is, tramadol really should not be on your radar. So we don't need to pull everybody off tramadol if they're stable. But a lot of folks don't do well with tramadol, so let's go ahead and try to figure out a better solution. So when our alternatives do not cut it, and you're saying, you know, I do have to move on to something stronger than that combination that I've been using, let's go ahead and try to reach for oxycodone 2.5. Most folks do really well, especially when we combine that with the alternatives. The alternatives are not working, you don't need to stop them, but we should go ahead and add a layer. And if we add a low dose oxycodone or low dose morphine to the alternative, we actually can spare some of that high dose opioid because we have such a multimodal synergistic protocol. Additionally, when patients are being discharged from the hospital and you want them to take alternatives, give them the medications you want them to take before they leave. We give them a prescription for the opioid, and then we tell them, go ahead and take an over-the-counter medication. Or when they leave the office, go ahead and buy acetaminophen from the pharmacy, go get ibuprofen, but here's your prescription for whatever else. A lot of times folks don't go get that over-the-counter stuff. So go ahead and give them it, write it on a prescription if need be, or have it available to them if they're in the inpatient setting. And then they have the bag of everything they need when they go home after you've had significant discussion with them and documented it as per New Jersey state law that you talked about alternatives, risks, benefits, safe storage, safe disposal, and how to take it properly. When we talk about chronic pain, this is really, we have a lot of discussion nationally about how to manage chronic pain. And, you know, some people in chronic pain, they need opioids every day and they do very well. They're stable, they're functional. We don't want to pull them off their opioids. They're doing well. There's a population of patients that don't do well with opioids every day when they have chronic pain. So really our goal as a country should be, we have a lot of opportunity to utilize alternatives, non-pharmacological interventions, everything listed here before we start down that road of opioids, because it's always going to be there for us. But we really should be exhausting everything else before we start patients on opioids, because there are harms associated with them. And I want to highlight the last bullet here, which is a medication called Belbuca. It's low dose buprenorphine. Buprenorphine is the active medication in Suboxone, and buprenorphine has classically been used for opioid use disorder. When given at a very, very low dose, a tiny dose to patients who don't take opioids every day, buprenorphine is extremely potent and extremely effective at taking care of chronic pain. But because of the pharmacology of the medication, it does not cause all of the side effects, dependence, constipation, and mortality associated with what we call the full agonist, or the higher dose oxycodone, Dilaudid, and morphine. So I could also speak an hour about Belbuca, I won't, but if people have chronic pain patients and you are trying to come up with something else, maybe even just a better opioid, please look into low dose buprenorphine. Extremely safe, extremely potent, and really has just a better safety profile. Again, with chronic pain patients, please look into your community. If you feel you're not able to continue to treat patients who have chronic pain, you are concerned that your only option is going to be opioids, but you don't think you're quite there yet, but I'm not sure what else to do. There's probably some folks in the community, especially in New Jersey. We have pain management, we have interventional radiology, we have ortho spine. We have a lot of physicians who specialize in pain. Just look around in your community, call up these docs and say, hey, listen, I run an outpatient office, I'm having some issues with chronic pain. I really want to capitalize on your expertise. Can I refer to you? Tell me what you do in your office. Tell me what insurances you take, and collaborate with your colleagues. If you're unable to care for the patient population and you feel like your only next step is to prescribe opioids, let's go ahead and see if there's another pathway that the patients will benefit from alternatives before we get to that opioid pathway. So really the summary of this portion is to talk about lowest effective dose of opioids with counseling that patients need. We talked about that. Shortest course of opioids, follow them up closely, combine your alternatives with your opioids. Try not to start folks on tramadol, try low dose buprenorphine, and let's talk about morphine sulfate immediate release as opposed to only oxycodone as our go-to opioid. And just very briefly, I do want to talk about the management of opioid use disorder. This is a disease that presents with withdrawal, but is also a brain disease. If we only detox and manage folks for their withdrawal, we're not addressing the brain disease. So to detox over 5 days and be sent back into the community and expect this population to function beautifully is very ignorant. We don't take patients who have just spent 2 weeks in the hospital because of severe medical disease and just send them back home with nothing. They get prescriptions and they get physical therapy, and there's probably a social worker, and sometimes they have to go to subacute rehab. We really optimize all of these medical interventions for patients recovering from severe chronic medical disease. That is how we need to view opioid use disorder. It is a brain disease. It is a severe chronic medical disease. Just because we've managed your withdrawal does not mean we've even touched the underlying issue of opioid use disorder. When we start medications like buprenorphine and methadone, we bring down the population's mortality almost to that of the general population. If the OUD population doesn't get treated, they die. So we cannot ignore them. We also cannot ignore that when patients go through counseling and cognitive behavioral therapy alone, they have a much higher mortality than if we maintain them on buprenorphine or methadone so their brain can heal, because it is a medical problem. So yes, they need counseling. Yes, they need psychosocial interventions. Yes, they need support. But in early recovery, they need their brain to heal like we need our bodies to heal when we are recovering from chronic medical disease. When you have people on maintenance buprenorphine, they use less illicit substances, they use for fewer days, they have longer periods of abstinence. You will save lives if you start using medications for opioid use disorder in your office setting or in your hospital. When we have a STEMI, an ST elevation MI, a heart attack patient come into the hospital, the whole hospital rallies around that one person to get them to an intervention that saves their lives called cardiac catheterization. Well, that intervention has a 2/3 mortality reduction. When we start methadone or buprenorphine, that has a 2/3 mortality reduction in the opioid use disorder population. So we should be rallying around those folks when they come into the hospital if we're in the business of reducing mortality. Do not ignore your opioid use disorder patients. You have buprenorphine, you have methadone, you have Vivitrol, you have addiction specialists, you have recovery centers. Abstinence works for a small percentage of the population with proper support and social infrastructure. The majority of people need medication, just like the majority of people with hypertension and diabetes need medication. So we cannot ignore the brain disease that exists with opioid use disorder. You can do home inductions, you can send them to the emergency department. And just like Mark mentioned earlier, there's fantastic new legislation where we need to be prescribing naloxone to all patients who take daily opioids, because unfortunately, there are issues with daily opioids as well with overdose. And we absolutely must be giving naloxone to patients who have opioid use disorder. New Jersey ACEP, New Jersey American College of Emergency Physicians, is doing a huge educational initiative for ED physicians looking to learn more about buprenorphine or Suboxone in the emergency department, how to use it, and how to link patients to care. So if you're an ED doc or you know any ED clinicians out there, tell them to go to this website. They must learn how to give buprenorphine. They must. They have no option. If they see opioid use disorder patients or opioid overdose patients, it is their duty as a clinician to know how to treat them and reduce mortality. So in summary, try to prescribe less opioids when you can, try to use alternatives when you can. Please don't ignore opioid use disorder, use buprenorphine, refer to methadone opioid treatment programs, and try to normalize this disease called opioid use disorder. It is not a moral failing. It is a chronic brain disease. And if you are going to ignore this population, then you're going to admit to yourself you don't care, and they're probably going to die. So not to be so morbid, but I think we really need to embrace all of the evidence we have to support treatment and to really rise up and help address this terrible, terrible epidemic we're dealing with. So I appreciate all of your attention and time, and I am going to hand it back over to our sponsors.
Thank you so much. Thank you, Dr. LaPietra and also Dr. Rosenberg. Great information. I know we have a lot of chatter going on in the chat. So I'll start with a first question. I'll throw it out there and perhaps you can both give us some feedback on it. But how important do you think it is to have these conversations with the patients or even with the patients' families about these alternatives? Do you get pushback from the patients? Do people understand that these alternatives, will help them? Or could you give us some feedback on that, how important that is and the feedback they get?
Let me jump in first, and then I want Alexis to add to this. Many people come to the emergency department, they just want to be out of pain, and they would prefer to go the way of least harms, least side effects, particularly if it's a mom bringing in her 8-year-old soccer player, or if it's a daughter who's bringing in her 85-year-old mom who just broke her hip. Nobody's saying we want them to have opioids. We want them to be comfortable. So it's our job as physicians to manage their pain aggressively and completely, but to use the least harmful way. And that's why this comes in. And part of the conversation is to explain that, because their neighbor may have gotten an opioid and they wonder why they did not get it. Let me ask Alexis to add more color to that if I could.
I agree, Mark. When we launched the program, we spend a lot of time talking to patients who in previous ED visits or previous office visits had received an opioid. And they were curious, whatever you want to give is fine, doc, but why would we not go ahead with the opioid? And when you empower folks to appreciate the research and the data behind the effectiveness of the alternative, they're really grateful that there was a conversation And they were really grateful that we're thinking about this. Just as mentioned earlier, we were not talking about this 10 years ago. We were prescribing opioids. And, there's so much trust in medicine, as it should be. Doctors and nurses and clinicians, we trained for so long to be able to care for folks. But as we learn new things, we need to share them with the community so everybody can work together. So we often find folks are relieved that they can take medications that don't cause sedation. They can take medications that doesn't prevent them from driving. They can take medications that don't cause nausea, vomiting, or constipation. And again, there's side effects to a lot of the medications we give, sure. But when you have a risk-benefit discussion with them and you let them know the alternatives will work, we can always escalate if need be. But there is pretty significant harm associated with opioids, especially for the problem you have today. So let's go ahead and try to avoid them. And you get to sit down, you get to talk to that human being face to face, you get to be empathetic with them, and you get to empower them. And that is really, really a lovely moment for a clinician to have, because that's really why we got into this.
No, I think, that's so great to hear, because I know I could just speak anecdotally on behalf of the people that I've spoken to, parents or family members who have someone suffering from addiction or lost someone. So many of them say the same thing, that they didn't know that there were alternatives. So thanks for sharing that. So we had a question in. So was there a decrease in the overall ER visits due to this new this policy or the ALTO program when you launched it? Did you see a decrease of people coming in?
So again, I'll start. There was actually an increase of certain populations, and I actually mentioned them in the last answer to the question. We saw more pediatric patients who were coming in because mom did not want her soccer star to get opioids for the soccer injury, but wanted them managed aggressively. And the same thing with geriatric patients who were frequently brought in by a family member or their daughter, it just so happened. And again, did not want mom to have constipation or dizziness, or worse yet, other problems that may come from opioids. But a fall would be devastating on top of a fall. So we actually saw an increase of a certain group. And we also saw an increase of those who were previously addicted or dependent who came to our emergency department because they knew they would be treated without opioids, which was both of our preference. So we did see some increase.
That was
All right,
perfect. I have
thank
nothing
you.
to add.
Yeah. Okay, great. And so I guess this is kind of a dual part question, but did you see any impact on your patient satisfaction scores for pain control? And if so, how do you get buy-in from administrators to replicate this program? What advice would you give other doctors who are on with us?
So I think that the role of the hospital and the role of the CEO and the foundation board, if it's a not-for-profit, is to really provide service to the community that they serve. And what we're doing is exactly what the CEO and the mission of the foundation needs to be, is to improve the care and the pain management of that 42% that come to the emergency department who come in with acute pain, and not provide harm. We did not see a decrease in patient satisfaction. Now, those who are drug seeking, indeed, were not happy with us. But those who were legitimate, it's hard to even say that, and I hate putting that word there, so let me restate it. Those who came in who wanted their pain managed loved the fact that we talked to them. We took the extra moment to not only explain what we were doing, but gave them maybe a trigger point injection or something that completely alleviated their pain. There was one case we had, I was with Alexis, and she was a woman who had tremendous amount of pain, and Alexis gives her a trigger point injection. She felt so much better. Spontaneously, she turned around and hugged Alexis and was just thrilled with the results of her pain management. You don't get that from giving people just a pill and telling them, see your doctor, and leaving it like that. So this actually helped our management of patients and our satisfaction.
And I'll also say, in terms of the administration, a hospital has a duty to its community to provide the most up-to-date and the safest care possible. So there's a hospital within that community. You have a population that probably routinely goes to that institution. Their physicians admit to that institution. They have surgeries at that institution. They have babies at that institution. That hospital has that duty to recognize that when there's evidence that has come out about mortality associated with certain drugs or the benefits of using alternatives, they have no excuse not to implement that. When there's drugs that come on the market that show mortality benefit, if you're going to withhold that from your patient population, then you're actually doing harm. So from the administration point of view, this is a fantastic way to show your community we are up to date, we are committed to addressing the crisis in our community, and we are getting everyone together to figure out the best course of action that aligns with alternative use, harm reduction, and management of opioid use disorder. If the institution is not going to recognize the harm reduction associated with an ALTO type program, then they're really saying, we know there's an opioid epidemic, but we're choosing not to fund efforts to fight it, and we're choosing not to be part of the solution. And that is really unethical in a time when opioids are killing more people than the wars we've had, and has become the #1 preventable death in people under 50 in our nation. So there's no excuse. If you're a clinician at a hospital that does not have something like this, that institution leadership must be made aware that there is evidence and there is support to launch these type of programs. And if they're not doing it, then they are not aligning with the mission they have to serve their community with the safest, most up-to-date medicine.
Alexis, do me a favor. Can you address other service lines other than the emergency department just briefly? I don't know if you mentioned it, but I think it's worth mentioning again.
Sure. When we launched ALTO in the emergency department, it was great. It was a hit. We ton of education, ton of resources, lots of time. And then our CEO, Kevin Slavin, who was extremely supportive of the program, said, you know, guys, thanks for doing such a great job in the ER, but we really should probably move this upstairs. So very quickly, we were tasked with getting everyone at the table and moving this into every single department. And there's not one chairman or woman, there's not one nursing leader who said, we don't want this. Everybody was ready. Everybody was looking to figure out what the solution was for their department. So with administrative support and with clinician buy-in, which was unanimous, we were able to take a look at the issues each department was having. And even if it's small interventions, start somewhere. And we're still in 2021, we're still looking at quality improvement. It's not, you know, can't snap your fingers and make all these changes, but it is not isolated to the ED. Whatever department you might start in as a pilot, you'll quickly see there's desire on behalf of the whole organization to do something and to get in line. And really, administration needs to be supportive of that from the top down for the whole house of medicine. One department is doing something and then a patient transitions over and that other department is not following in line, then all that good work sometimes, you know, that's done initially can be undone. So it needs to be a collegial, collaborative effort, and the silos need to be broken down.
All right, great. Thank you so much. I know we're coming to the end of our time, and I want to give you guys just one more opportunity. If you just have one closing thought that you want to share. Right now, a poll is being launched for all of our attendees. If they give us some feedback, we would appreciate it. Dr. Rosenberg, is there a closing thought you want to share with the attendees today?
I think so. You know, and I had said it that we have choices. We can either be part of the solution or we can be part of the problem. And I think learning to be part of the solution is a win-win-win situation for our neighbors, our family, and even ourselves as individual professionals, regardless what field of medicine we're in. So thanks everybody who's on the call. Really appreciate talking with everyone.
And I'll just say, all it takes is one person in an office or one person in a hospital to get, you know, a little passionate and to sometimes collaborate with, you know, friends in other institutions or professional organizations to just go to your medical director, go to your chairperson, go to your CMO and say, we're not doing what we should be doing. So don't hold back. As clinicians, we are the advocates for our patients and our community. So be bold, reach out, start talking about it, and you will find that there is support. Sometimes the conversation just has to be started. So please reach out. Please reach out to your professional organizations. Please advocate on behalf of your patients for quality pain management and quality treatment of opioid use disorder. And I know we can change this. It just takes a little passion, a little caffeine, and a little collegiality.
That's a great way to end. And I know there's been a lot of comments in the chat asking if there's some protocols that are available or some procedures that can be replicated in other hospitals or in other states. So we'll connect with you guys and be able to share that information as much as we can in an email that will be sent out to all of our attendees after this event. So just wanted to put that out there. There'll also be a link to a recording of this, as well as copies of the slides. Once again, I want to thank our expert panelists. I think we had some great information that was shared, some great perspective and conversation. I want to thank the Opioid Education Foundation of America, the Partnership for Drug Free New Jersey, New Jersey Office of the Attorney General, and NJ Cares. On behalf of all of us, I want to thank all of you for being with us today and really learning about these alternative options that are available. I thank you all for joining us, and I wish you all a good afternoon. Be well and have a good day.